Good evening, everyone. Thank you very much for joining us tonight for this very special occasion, the inaugural lecture from Dr. Will Herrington. I've had the pleasure of working with Will for about 14 years, and I'm really looking forward to this evening. I just want to say a few words about him before he starts, in case he tells fibs about what he's done. So Will qualified in medicine from the University of Cambridge and from UCL in London in 2003. And after his general medical training, he then joined the Oxford Deanery, where he trained in renal medicine from 2006. And then in 2010, he came here and joined us in CTSU and worked chiefly on the SHARP trial, and then got involved in other things as time went by. And then he was really trying to develop trials in renal disease, and we had a few false starts, but then along came the EMPA-KIDNEY study, and Christoph Vanner, who ran that study, is in the audience down there. So we all got very excited about the Empagliflozins. Will led the way on EMPA-KIDNEY, which was spectacularly successful. And he managed to do that during COVID, when everybody else was faltering. We were able to work together and make that happen. So he really did a fantastic job on that. And since then, he's been working on trying to answer another question, which is really needs to be answered, and that's the role of aldosterone inhibition in in chronic kidney disease. And so he developed with others the EASY kidney trial. I'm not sure about the word easy within the title of the trial, but certainly we've screened the first patient just in the last few days, and so only another 11,000 to go. I will say that what's really remarkable about Will is his enthusiasm, boyish enthusiasm is what I would say. And if you've worked with him, you'll know that's absolutely spot on. I did wonder when he first came here, is he old enough to be working in CTSU? But he's really shown his mettle. And I think that the award of full professor last year was richly deserved. And I'm really looking forward, as sure we all are, to hearing about how he pulled it off. I'll just remind you that we've got canapes, drinks afterwards, and there are no questions at the end. So really, you'll have to save those for when we get outside. So thank you very much, and we look forward to Will's talk. Thank you.
Thank you very much, Colin. That's pretty much the talk done. Any questions? I'm very grateful to all those of you who've travelled, some of you from very large distances to be here today. The title of the talk is The Rise and Rise of Randomized Trials in Renal Medicine. It's a journey that I've been on, but I think the nephrology community has been on, and I've just been very grateful, proud to be part of CTSU and grateful to have been on the ride. I have to admit that the reason I applied for the recognition of distinction was actually to try and help renal trials rise further as we are trying to build new collaborations internationally. And the main reason for not wanting to apply was today. I'm well aware that, that some of you will still be sober, and that you will want to get to the drinks. And it's 45 minutes of talk with no questions. And I know Richard Peto will not be able to control himself. Anyway, so there was a lot of anxiety writing these slides, so much so that I wasn't actually quite sure exactly even the title. And so Guy, myself and Charlotte spent a lot of time procrastinating on the first slide and decided to offer you both spellings of the word randomized. But whichever way you spell it personally, I hope we'll all agree in the value of randomized trials. I think we'll all be thinking about that in the background of our eyes opened my eyes were opened to it by Colin and Martin Landry, in 2010 when I came to CTSU. And now what's really lovely about this is that we are now beginning to see that magic filtering down into clinical practice in renal clinics. I can see the evidence that we've been generating here used almost in every patient I see, but also we see it percolating internationally and also across into primary care clinics and into cardiology. And it's felt really rewarding to have seen that journey. And I just wanted to show you a bit about how I've experienced it from my perspective. So, kids, this is a story of the rise and rise of randomized trials, but we don't start with once upon a time in academia. We start with a rather boring slide about disclosures, which is the fact that we all here follow a departmental policy to not accept personal honoraria funding from pharmaceutical or food industries for the meetings we go to. And that ensures our research independence. And I'm glad Rory isn't here today, Colin, because I've got a bit of a confession. For many decades, I've been supported by the alcohol and food producing industries because I am the progeny of a paternal master brewer and a maternal Kentish farming family. And this is 1978, if you want to know how old I am, in Kent, in front of a farm called the Batteries, with Julian and Alison, my mum. My dad actually brought me up initially in Wales. He was training in brewing, and I remember going to the operations room in Magor in South Wales, where my son broke his clavicle just a few weeks ago. And then also moving to Weymouth, where he was a brewer at the Devonish, which closed. Nothing to do with his recipes, I'm assured. And then at 6, we moved to Kent, back to my mother's maternal, a childhood area, where there were hop gardens on the way to school. In fact, there were hops all over the kitchen. And the main street of the town, which was Faversham, was adorned with a hop encrusted building. And in fact, all those buildings you can see in the bottom right are the brewery. And it dominated that street, both visually and with the smells of my dad's concoctions. And the family claim to fame is this, the Spitfire beer recipe. He and a colleague made the recipe to commemorate the 50th anniversary of the Battle of Britain. It's famous somewhat for its taste, perhaps more for the bad taste of its slightly xenophobic advertising campaigns, which actually got banned. They're still available online. This is about the only one I can offer. I'm very sorry because they're rather anti-Germanic, Christoph, which is a real shame given the warm and close collaboration we've had with Würzburg over 20 years. And also the funders of EMPA-KIDNEY and EasyKidney. Anyway, I'm going to get onto science soon, but I wanted just to stay with Spitfire beer because it's a bitter, an aromatic allure. It has hints of marmalade, red grapes, pepper, thrusting from a springboard of warm mellow malts. A floaty, fruity finish signs off with a smidgen of spice and raspberry. And this very much sounds like my dad's cooking. And I had a very healthy, very nutritious upbringing because my mum cared for my food and I had a very stable home life and my dad was kept out of the kitchen. Spitfire is actually named after, obviously, the aeroplane, not the effects that spicy raspberries have on your alimentary canal. But if you are interested in spicy raspberries still, then after the talk, Guy has a few bottles of beer of Spitfire, which you can try if you don't want the sparkling wine or orange. And he might even pass you one now, should you not be able to wait. So, there are no hands, Guy. You can have one. You can keep it to yourself. So my journey from hops to nephrology was actually one which was somewhat in blissful ignorance of the importance of maths and population science for clinical trials. In fact, I didn't actually want to be a nephrologist when I started out. This was my first day at school. I was really pleased to find this photo. My parents were abusing me by making me wear sandals and an oversized Mac. And I did feel very grown up. But actually, my education was very stable because we moved to Kent. And I actually spent 11 straight years at Kent College, the junior school, and then the senior school, which was a school. I don't think it was a particularly academic school, but it offered many, many opportunities. You can look at the ratio of sports grounds here to classrooms. And there's a photo here of me playing cricket. That's by Paul Smith, who actually taught his first maths lesson and my first lesson at a secondary school. He's in the audience, happens to live on the same road as Carl now. He's with his wife, Penn, who worked in the Churchill Hospital. It's a very small world. And at some point, he now flows for British Airways. I hope at some point we'll be able to fly me to some of our academic meetings. But the other person I'm indebted to at Kent College is someone called Stephen Fell, who rather poignantly I discovered died during the COVID-19 pandemic. He was someone who had actually an important impact on my life because I told him I wanted to study medicine. I said I wanted to do it at Cambridge. I needed to study for S-levels. And he provided me with a series of A-level papers from the past and also O-level papers from the 1950s and 60s to revise for S-levels. S-levels are above O and A-levels. So very much respect to those of you in the audience that might have studied chemistry back in the 1960s, because that's what I used to revise for S-levels to get to Cambridge. And Stephen Fell really was the person that really supported me. He taught me about self-directed learning and gave me that opportunity. The other opportunity the school offered was experiences with international boarding schools and girls. And on the left there is my wife Sandy. We met in 1994. We went to our first date, 30 years ago. We went to the film Speed. Keanu Reeves and Sandra Bullock were on in the Canterbury Cinema. And Sandra Bullock does warn at the end of the show that relationships that start under intense circumstances, they rarely last. But thankfully, the combination of a Knickerbocker Glory and a 2-hour film wasn't too exciting for Sandy, and she became part of the family. And this is a photo of her and I at the school Leavers Do. And the other opportunity that Kent offered was drugs and alcohol. On the left, you can see the Sun Inn, where I worked in my summer jobs, supporting the brewers with their soup lunches and their Spitfire. But on the right was the Kent and Canterbury Hospital, where there was a phase 1 clinical trials unit, which did pharmacokinetic experiments. And I spent summer jobs there doing phase 1 pharmacokinetic studies, blood pressure lowering drugs, which only needed to be studied in men because they had a curious side effect. And those that were taking the active treatment were quite clearly the ones that were sitting down, and those that were taking the placebo were clearly the ones that were able to stand up and play pool. Anyway, the combination of opportunities in Kent of being able to experience some clinical research, experience a stable schooling, and also the ability to be able to have schoolmasters who would push me beyond the norm actually enabled me to secure a place in Cambridge. And I went to Downing College, and this is the paradise of the college. I managed to get through the ballot, what I thought was the best room in the college. You can see its proximity to key infrastructure. I think it was probably the closest room to the lecture theatre, the university lecture theatres possible, which is perfect for someone who's perennially tardy. I remember vividly reading for the first time about this gentleman called Richard Dole, who, for those of you that are not aware, is the gentleman that's sitting in that picture on the right, standing at this lectern, and about the British Doctors' study in smoking. But I wasn't really interested in population science at the time. I was interested in two things. I was interested in viruses and how they cause cancer, because I wanted to be an oncologist. And I was interested in catching the National Express to Warwick to go and see Sandy, where she was studying maths and statistics. And we decided at the end of my time at undergraduate actually to get married. And we moved together to London. Sandy started training as an actuary, a pensions actuary, initially at Aon and then with the government's actuary department. There were survival curves and life tables everywhere, and I'd never noticed them at all. Because I was busy trying to become a doctor. This is the Middlesex Hospital on the left. I had that room right at the top. It felt like a little bit of the Harry Potter world. And I actually started my first general medical job, and it happened to be a nephrologist. And this was the first time I'd taken any notice of kidneys at all. I'd skipped all of the physiology lectures because they just were slightly too far to walk to. But the lead of the firm was Professor Leon Fine from UCLH, and I had two registrars, Kieran Harron and rather poignantly, a doctor called Emma Preston, who never quite made it to consultant because she died in an avalanche just beforehand. But they persuaded me that nephrologists were the best medics in the hospital. They could look after people who almost needed to go to intensive care. They could do all of the procedures, and they could see the holistic and care that people needed. And they persuaded me to apply for a job, and I applied for a job at St Mary's as a senior house officer in renal medicine. And that was my first taste of what I thought was a really intense and exciting specialty. 100-hour weeks were the norm back then. I witnessed what I thought was the most revolutionary treatment of dialysis. We saw people who were coming in with pulmonary edema. I was used to treating them with furosemide, but you could put them on this machine, and within 4 hours, they could go from what looked like life-threatening pulmonary edema to be walking out of the hospital. And they'd come back 2 days later, and we'd have to do the same thing again. But we felt like we were saving people every 48 hours. And then there was this audacious concept of transplantation, which revolutionized the standard of people's lives. And we had lots of young people who, no fault of their own, had kidneys that failed and whose lives were put back on track by transplantation. I was absolutely taken by nephrology. I made a conscious effort to read the Nephrology Dialysis Transplant, the NDT Journal of the European Renal Association, as often as I could. Sam, who's in the audience, who I shared a flat with at the time, might not remember the piles of them next to the toilet in the bathroom. And it's been a pleasure working with the association, actually, for more than 10 years as an editor now. I never dreamt that I would be an FERE either. But this was the path that got me onto nephrology. And I managed to use that knowledge to con Phil Mason there on the right, to giving me a job, my first registrar training post. I didn't come to Oxford through any design. It was the first training post that became available. And I turned up to interview, and I'd been reading NDT for a while. I wasn't that particularly experienced clinically, but I had a bit of knowledge, and I thought I was better than I probably was. I was carefully looked after by an older brother, senior registrar, Nitin, as I joined the Oxford Kidney Unit, and I was mentored by a series of people whose faces I can see in the audience. Vascular access, I was Emma Vaux on the left carefully helped me improve my skills and helped me write my first conference abstract. Chris Winnels and Chris Pugh, second and third from the left, encouraged me to think about pharmacokinetics given my experience working with VIDA, and I was interested in metformin. And I wrote textbook chapters, many of them, with Aaron Shakira and Chris O'Callaghan. And my first review article was written with Phil. Phil, I'm so sorry for how many revisions I had to put you through. But in the end, it actually started me understanding what evidence there was that was behind the teaching that you were giving us on the ward. And it was formidable, the understanding and the logic that you were implementing. And I really started to enjoy my training. But looking back on it, there were certain data which haunted me. And this is the period of training where nephrology was in a slight problematic period. We'd obviously established transplantation, we'd obviously established dialysis, but here was some data that really struck home. It was a 30-year-old patients, 40-year-old patients on dialysis. If you looked at their cardiovascular, their mortality rate, you saw it was the same as an 85-year-old from the general population. And this was striking because, in actual fact, we were selecting patients who were more healthy to go onto dialysis. So someone on dialysis was as likely to die from cardiovascular disease as an 85-year-old. And then on top of that, despite the high clinical need, nephrology was not publishing as many trials as other specialties. This is the numbers of trials published within the PubMed system. And you can see here, it's a very famous slide, almost at every conference you see this, that nephrology is the green bar at the bottom. We were producing the lowest number of trials. We also didn't have any evidence of growth. And on the top was cardiology and oncology. And in actual fact, there's lots of studies showing that 10 years on, this hadn't really changed. And in fact, we were doing a lot of open label trials with small sample sizes. And then, as I was getting more into the evidence, something even more depressing started to happen. So when we did publish a trial, it seemed that for some reason in nephrology, the drugs didn't work. Set up journal clubs with people in Reading and Oxford, and now when randomized trials are published, normally in the New England Journal, we pulled them up for discussion. And on the left is the 4D trial. Christoph Vanad showed how you could randomize more than 1,000 people in a single country in a multi-center trial, and they're testing a statin versus placebo, and demonstrated that the drugs didn't work. The atorvastatin seemed to work in everyone except for people who are on dialysis, that group of patients at extreme risk. And then rather depressingly, we had been using EPO for 20 years very effectively to reduce transfusion risk and exposure to blood products in people on dialysis. But in actual fact, when we started to assess whether or not if we could fully correct people's anemia on dialysis with the EPO, in actual fact, we'd been causing harm. And we probably didn't know that we'd been causing harm through stroke for 20 years until we'd done the trials. And it was a conversation about this with Marion Maffam on the Victoria Ward in Royal Berkshire, which is a real major turning point in my life, because she told me about this gentleman mathematician based in Oxford and this Bampton-based Morris dancer. And that's Colin Bajan and Martin Landry, who had randomized over 9,000 people with chronic kidney disease in 18 countries, helped by Marion, but also helped by the Sharpette who's Kirsty Reith, the lady in the middle of these pictures. And they have really started to work on trials. Marion told me the job would be incredibly boring. It would be repetitive. I'd learn a bit about trials. I wouldn't get much out of it myself from publications perspective, but I would be part of something which would have a key impact on clinical care. And I decided that sounded like a really good idea. But it was really the beginning of the rise of clinical trials. And at the same time, there was John Emberson, who was working as a statistician with the group, and there was Richard Haynes, who was also a nephrologist 3 years older than me, who was beginning to be able to set up trials. And I was really excited by joining Sharp. And I joined Sharp with this gentleman here. This is Dr. David Lewis, who is a nephrologist who started training at the same time. And we worked together as a team working on Sharp. And our job was to look at every single outcome of the trial. With 9,000 sick dialysis patients, there are actually 13,000 potential outcomes. And we had to collect medical notes from the hospitals, and we had to verify the reported deaths and heart attacks and strokes. On a good day, we could do 50. On an extreme day, we could do 100. So you can see how long it would take to do this. And these are often in multiple languages because we had 18 countries. We did lose the plots, David in particular. We did have to work through the holidays, and there was a rush, there was a deadline, because the trial needs a report. And back in November 2010, we were very excited to go to Denver and to watch Colin and Martin present the results of Sharp on the stage at the American Society of Nephrology to a round of applause. A moral stancer from Bampton had given atherosclerotic disease, heart disease, a kick in the teeth. And for the first time, we could really see in a large trial, in the time I had been in renal training, a drug which was effective, a 17% reduction in the risk of heart attacks and strokes. And I was able to witness the effects this had on guidelines. KDIGO commissioned a dedicated guideline on lipid management. And I spent a lot of time with Colin explaining the results of this to regulators. And I began to see the impact this had globally. From that time, I rather selfishly spent a lot of time trying to teach myself about epidemiology and how the trial had been done. And John Emberson very kindly spent an enormous amount of time supporting me, teaching me statistics of running trials. And my MD thesis was based on stroke from Sharp and also incorporating the stroke data and some of the other data into the cholesterol treatment trial. So this was a paper that resulted from my MD thesis. It happened a few years after I finished my thesis, 3 years later, but that's what collaborative science is about. And I learned about how running trials and doing these analyses was like growing trees. And it was actually 2 years after the Sharp result that I actually realised that fundamentally I thought that I maybe had made the wrong choice about wanting to become a clinician. As I was sitting at the ASN meeting, coming to the end of the period of time where I was as a clinical research fellow, and there was this trial reported. This is called the Evolve trial. Now, the Evolve trial was testing a drug called cinacalcet versus placebo. It was affecting a hormone in the neck, which was thought to accelerate vascular calcification, so the hardening of the arteries that we see in patients on dialysis. We spent enormous amounts of time in nephrology trying to modify this, dietitians, drugs, vitamins, to try and modify and control the calcium and phosphate in the blood. And I assumed this trial, which was the largest ever trial of people with dialysis, was going to be rip-roaringly positive. But the trial was negative. Its chances it was a false negative. There was some bad luck with an imbalance of age in favour of placebo, but also there was a large amount of patients who stopped taking their treatment during the study and dropped into using cinacalcet. Nephrologists had become certain, because we could manage the hormone levels in the neck, that the drug must be effective. And so as a result, the trial could have been a false negative, and we'll never know. And the trialists reported the results in the New England Journal of Medicine. He had another depressing journal club in Oxford this time. But what was really nice is that the people who ran the trial reflected on how the trial had potentially been a false negative and the lessons they learned from it. I recognised that the trial had not been designed in the way that if Colin and Martin had designed the trial, it would have been done. There would have been several different features to the design. And it was really an epiphany sitting and thinking about this that made me realise I needed to spend more time on trials. And this is what I thought to myself. It says a mismatch between the extreme personal health and economic costs of kidney disease and the amounts of reliable evidence from trials. We see the high level of cardiovascular mortality, and we saw the lack of trials. That complete mismatch. But there was also an underappreciation from, I think, the community of the value of randomization. We had the largest ever dialysis trial, but people were willing to start using the drugs before we'd actually proven they worked. And then there's this enormous administrative burden. Running a trial is incredibly boring. The funding can be precarious, and your trial may be maybe take you 5 years to run it, could collapse at any time. And it seems to be the forces are always pushing you to try it. Entropy tries to rule, and well, there was a limited number of people willing to take this on. I thought we needed more dedicated nephrology trialists. I think there's an urgent need for more clinicians to stop doing clinical work, because we were seeing, caring for 300 dialysis patients in some cases, Phil, and we weren't having the time to clear our headspaces. So I decided to take what I thought was a risk at the time, but to follow Richard Haynes in the model of a nephrologist becoming a trialist and really carry on under the wing of Colin and Martin. And I was really grateful for them offering me some funding to come back here to try and establish myself. And I tried to establish myself, first of all, with trials. I was obsessed with the idea that we could treat aldosterone. Other trials in heart failure have shown that this drug clearly reduced the risk of heart failure, hospitalization, and cardiovascular death in people with heart failure. And people with kidney disease get heart failure. And I thought it could also benefit the kidneys in terms of progression. And I tried to get funding for the British Heart Foundation for a trial called Achieve, which was a multinational trial being set up for spironolactone versus placebo. That failed on first submission. I submitted to a drug company called Bayer, trial designed to study people on dialysis, and I also to a company who was developing a type of drug which targeted the pathway. A small company. I suggested 2 trials, and then we met with them serially, and again, failed to attract any interest. I'm really grateful for Paddy Mark, who took on the spironolactone BHF application, and that trial is now real, but I abandoned aldosterone for a short period of time. And instead, I used what is my spare time here, whilst I was trying to set up trials, to essentially retrain myself experientially from being a nephrologist to being an epidemiologist and trialist. And we were encouraged sometimes at the quinquennial reviews by the external assessors to go and take experiences elsewhere around the world. I completely ignored their advice because it was absolutely unnecessary, because the world of epidemiology was centred around Oxford, in my opinion. There was Colin, Richard and Martin in the bottom left, who were running the renal studies group and had the UK Heart 3 and the 3C trials, and Colin introduced me to the KDIGO group and helped me become a scientific advisor to their controversies conference. Martin introduced me to Michael Goldacre, who had the record linkage study, which was set up the first methods to record from hospital records the passage of people through hospitals, and we looked at the first transplant patients and dialysis patients that had ever been looked after, and we looked at the epidemiology and how their trends had gone over time with Ben Story. Martin introduced me to the Clinical Trials Transformation Initiative, and I started to learn about how to simplify trials. I've also already mentioned the cholesterol treatment trials collaboration. There's Sarah Lewington and Robert Clark in the bottom, in the middle, brown hair and white hair for those of you who don't know them. And they allowed me time to literally dip into their meetings and work with the respective studies collaboration. They'd established these data over many years, and they were very generous with their time, allowing me to write papers, learn about the statistics. Zhengming Chen and his wife Yiping allowed me to look at the renal outcomes in Kadoorie Biobank. Bobby, their long brown hair, taught me about health economics. And Gemma and Natalie have supported me as I tried to dabble with a bit of genetic epidemiology, which I've decided to leave behind in the most part, I think rather sensibly, I think from their perspective. But I wanted to introduce to you something which I spent a lot of time doing, which was very influential in terms of my life, which was the Mexico City Perspective Study. I spent a lot of time with Richard Pito and John Emberson. John used to laugh that it was part of the CTSU coming of age, spending your time with Richard Pito writing a paper, as he would push me towards the door on a Friday at 5 o'clock and wonder what time I might get home, which was often well beyond dark. But I had a fantastic time working on the Mexico City Perspective Study. It had been set up by Rory and Richard and really was the forerunner of the blood-based cohorts. I'd seen it as such and was really excited by this study. Gary Whitlock had been curating it and sadly passed away, and John had taken it over. But essentially the study was an amazing study set up initially to look at smoking, but in actual fact it recruited a population at the early part of an obesity epidemic, which had started much earlier than the obesity epidemics that we see in high-income countries now. So in 1998 to 2004, 150,000 people were recruited in 2 areas of Mexico City, and half of the women were obese and about a third of the men. And as such, by the age of 60, about 1 in 5 men and 1 in 5 women already had diabetes. And compared to the UK at the time, it was that figure was 6%, and the US was 9%. So this was an obesity epidemic which had started early. And what was striking was that this was a very common condition, one in 5 people, but the association between having this condition versus not having it, if you were aged 35 to 59, was a 5 times increased risk of death. So 1 in 5 is the statistic that Richard told me, dying 5 times more commonly. So an extreme association. The data from the high-income countries where most of the science had been done before, this was a middle-income country being studied, the data from the high-income countries were doubling of risk. And of course, a disease which is as prevalent as 6 to 9% and doubled your risk was not as important in terms of the impact of health on the country as a disease which is as common as 1 in 5, and it quadruples your risk. And what John allowed us to do was to spend time trying to work out why people were dying. And what was really interesting in Mexico was that the death certificates, which we reviewed them, was telling us that people died of diabetes. Well, we'd seen that already. But what was really intriguing is that coronary heart disease was less common than dying of diabetes, and stroke, which is what the S stands for, was even less common again. Whereas if you look in the UK data, and this is data from for males and females aged 55 to 74, and the UK data is on the right, you could see that heart disease, CHD, coronary heart disease, was much more common cause of death in those age group, and diabetes as a cause of death was vanishingly rare. And so we wanted to know what on earth these patients with people with diabetes were dying from if it was diabetes. What does dying of diabetes mean? Well, we looked at the death certificates, and here is what we began to see. We began to see that in Mexico, they curiously filled death certificates differently. If you were a house officer, junior doctor in the UK, this is what you would be called to do if one of your patients died. You'd have to attribute a cause of death. And the top part of the death certificate is the immediate cause of death, and then the B, C, and D are the antecedent causes. What were the triggers that led to the final cause? Part 2 is where you put anything else that might have contributed. And you can see here that this death is a death from type 2 diabetes, which started 20 years ago, with blood pressure, which started 10 years after that. And then 10 years later, the patient had a heart attack and died within 1 hour. Okay, so this is telling you that this person died immediately of a heart attack. In the UK, high blood pressure and diabetes would have been banned in part 2. And there's just a simple rule in the WHO for attributing causes of death, which meant that if you stated diabetes within this top part of the death certificate as an antecedent cause of another vascular or circulatory death, then you have to accept diabetes. So these deaths are being reported as diabetic deaths. In actual fact, this is a heart attack death. And you could see examples of this with stroke and with other vascular disease, peripheral arterial disease, with renal disease, etc. And so we set out with clinicians in Mexico simple algorithms to try and recode what we called the epidemiological underlying cause of death, the cause of death in people with diabetes, which was beyond diabetes, and only accepting diabetes as the underlying cause of death if it was actually diabetes, by which we meant a glycemic crisis, a sudden low or a prolonged high blood sugar. And this was the result of what we saw. So this is the Mexico death certificates, look very much like the data from the WHO, cardiac disease being less common than diabetes. Once we reattributed, we found an awful lot more cardiac disease, we found more strokes, but we also found an enormous amount of kidney disease. There's still a horrible number of acute diabetic crises. And what we could do with this, and I'm cutting a long story short, is we could actually assess the relative risks, so how more frequent you were to die of a kidney cause or an infection cause or a vascular disease. And we found that the key causes of death among people with diabetes, with renal disease and cardiac disease and infections. And what this chart shows you is that for those that have diabetes, and they are essentially aged 35 to 74, what is their risk of dying of renal disease? And it's rather extreme, up at 30%. Cardiac disease, it was 20%, and here we are with infectious diseases between 10 and 15%. The white bars at the bottom are the risks in people without diabetes. So this blue shaded area here is the excess risk that diabetes conferred. And you can add up all of these bars and you can look to see what the total excess mortality was. And the bottom line of this, when Richard Peter presents this, is he just says, in actual fact, if you consider this indirectly or directly as the cause of death, diabetes, in actual fact, in this cohort, in the period of time that we had observed it prospectively, in actual fact, about 1 in 3 deaths in adults had been due to diabetes. And when you state this to the Undersecretary of Health, who'd helped set up the cohort, it causes action. And actually, there was an immediate government announcement that diabetes was a public health emergency. This is the first time the Mexican government had declared health emergency on anything which was non-communicable, so that infectious diseases were often declared health emergencies. But this was a condition which was common as 1 in 5 by the age of 60. And I saw immediately the impact that a large-scale study could have, what collaboration with international experts could do. And it left, obviously, a key piece of learning for me, but also a key publication. And these were the people that helped. I mean, I was just part of many people within the collaboration. What it helped me do was secure my first personal funding. Kidney Research UK and the MRC funded me and funded a bit of extra field work in Mexico to start to develop a better understanding of adiposity and kidney disease. And it was really the first step forwards. And I continued working with all those people I showed you in the earlier slide. But behind the scenes, I always still wanted to run trials. And this gentleman here interrupted my fellowship. He deserves that gold medal and the velvet hat, because this is probably the most important finding, I think, in nephrology in the last 20 years. This was the EMPA-KIDNEY outcome trial. It was a completely surprising result. So this is a drug which makes you pass sugar and salt into the urine. It was designed to treat people with diabetes. It's not actually that good at treating diabetes because you just... Careful, guy. Because essentially people eat a little bit more, and so you get a bit more hungry when you take the drug. So it actually doesn't lower your blood sugars as well as it could. But what it did was fundamentally transformative to the kidney. It actually reduced risk of heart failure, but this was a second paper from the study which showed that if you took this drug, and the people that took the drug were the yellow and the orange bars, there was a drop in their kidney function. And you might think that's not a good thing. You don't want your kidney function to drop. But in actual fact, after it dropped, the decline stopped. And the people that were offered the dummy pill, the placebo, in blue, their kidney function slowly declined over time. And when you stop the drug, you then got this recovery of that dip in kidney function. So 4 weeks after the drug, that red blob is then the recovery. So this was an irreversible dip in EGFR and then an almost arresting of the decline. Now, these were people who had generally preserved kidney function, and they were people who were being tested to see if this drug was safe from a cardiovascular perspective. And we thought to ourselves, wow, this is a large effect. In fact, this led to sort of 40% reductions in the risk of progression of their kidney disease to serious levels of kidney failure. But we thought if this drug is half as good in people with less kidney function, then we could really try and delay the time for people needing dialysis. And this is the beginning of the rise of clinical trials in nephrology, because myself and the newly appointed Professor of Metabolic Medicine and Clinical Trials, David Price, congratulations, David, wherever you are. There he is. We started sending proposals to 3 companies to run a trial, and we eventually got Boehringer Ingelheim, the manufacturers of Empagliflozin, the drug that was in the EMPA-KIDNEY outcome trial, to fund a large international trial. And we set about trying to recruit 6,000 people. And we did that by going back to where we'd been shown how to do this before with Colin and Martin and the Sharp collaboration, picking the biggest and the best countries. We thought that was a solid way to do this. The company said we'd like to also study Japan, and we had amazing support from Rionfa. Lee, I had no idea what I was about to go into. She must have known what we were about to go into. Trying to do a trial in Japan for the first time was like trying to recruit 3 or 4 countries, and we needed to expand the team. She looked after them and did a fantastic job. And Japan really made a major contribution to the trial, and is one of the things I'm most proud about when we look at the EMPA-KIDNEY results. But Rionfa, together with Rajiv, Dayanandan and Carol and Richard Haynes, we were the legs behind the thinking behind the operations of the trial. We managed to recruit patients all the way through COVID-19. COVID tried to scupper us. We got halfway through, 3,000 patients recruited, and we suddenly had to shut. But we managed to scrape through eventually. And when you look back at the numbers of people involved in the trial, we had 6,609 participants who took study treatment every day for 2 years, but also we had about 240 sites. And if you add up the numbers of people in our publications, it's actually the collaborative effort of 10,000 people around the world. And it's frightening that it's done from the office up there with the funny snacks on the table and the jokes that go on. But that's what we managed to achieve. And other people were thinking about these drugs. Other people had seen the EMPA-KIDNEY outcome result and were excited. We didn't know this at the time that we're designing other trials in heart failure or kidney disease. We had no clue. We designed the trial how we wanted it to be tested, and we actually ended up presenting the results of the trial in 2022 after a subsequent 11 other trials had published. So we were right at the end. And we thought to ourselves, well, maybe there's no new news when EMPA-KIDNEY publishes. But it did, because we followed the CTSU idea that we need to study wide ranges of people. So we'd studied 6,000 people at risk of kidney progression. We studied much larger numbers of people without diabetes in the other trials. And we've studied the types of patients which hadn't been recruited. In fact, we decided to recruit lots of patients from nephrology clinics. Much of the other studies had really collected people with much more preserved kidney function well before they were at risk of progressing to dialysis. The design was really simple. It was the standard of care with a drug which we'd shown to work about 20 years ago, randomized, which means a toss of a coin, a play of chance, allocation to the active drug empagliflozin versus the dummy pill. And we were waiting for 1,000 people to either die or start dialysis or to have important reductions in kidney function. But we didn't have to wait that long, because after 2 years, the trial was stopped early because the drug was too good. We got to 990 outcomes, though, and this was the result which appeared to us when we unblinded it. It was 558 people who had died from cardiovascular disease or progressed to need dialysis, or who had had an important decline in their kidney function in the dummy group, versus 432 in the empagliflozin group, 17% versus 13%. That's just over a quartering of the risk in a very short period of time, with just taking a pill a day. And gratifyingly, this was very much data on kidney disease progression. So we were nephrologists who were interested in how the kidney works. 888 of those 990 primary outcomes were kidney disease progression. And if you looked at the most severe parts of the outcome, then those people who started dialysis or had cardiovascular disease, then we could see we had reduced the risk of those really serious life events by about a quarter. Importantly, we showed something which I was not expecting. We showed that for that outcome, that the effects were just as good as people with and without diabetes. This was actually, I think, one of the first times we could demonstrate within nephrology that a theory that there's a final common pathway of progression of kidney disease and that it exists. There's an idea that once the kidneys get damaged, then a bit like a car, when the engine is damaged and you've lost a cylinder, the engine has to rev a bit harder to keep the kidney going, and you're going to progressively lose further cylinders. And if you can down-tune the kidney so that those other remaining cylinders don't work harder, then you might slow progression. This is how I explain it to my patients. You might have a better analogy. But essentially, that's how empagliflozin works. And we demonstrated that this may well be true with randomized data. But then we also found this result, which was also surprising, because we were expecting that as your kidney function gets worse and you pass less salt and sugar into the urine, the drug would become less effective. So if it was 40% benefit of preserved kidney function, like an EMPA-KIDNEY outcome, if we had half that, we were expecting perhaps half the effects. But we didn't find that at all. We found that, and this graph shows that in actual fact, the overall result of the trial was actually consistent irrespective of your baseline level of kidney function. And for those of you who are not used to looking at this, less than 20 is actually quite close to dialysis. 10 is where we are when we start talking about dialysis. Above 45 is still someone who gets to kidney clinic. But you can see those boxes in the middle, they're all aligned up. There's not even the suggestion yet of a threshold of kidney function below which we didn't start to give benefit in the patients. So the filtration of the kidney, if it was still functioning to some degree, this drug seems to still benefit. I'm still surprised by this whenever I see that result. And it really started to question one of the points that a lot of I'd heard during my training was that sometimes it's too late to treat people. It's too late to reverse cardiovascular disease once you get to dialysis. It's too late to slow progression once you get seriously advanced kidney disease. It's not too late. It's almost never too late when it comes to starting SGLT2 inhibitors. And the drug was surprisingly safe. It does cause ketoacidosis, which is a type of acid buildup in the blood, but it was surprisingly safe for something which was so effective. And when a drug is safe and has such large effects, then you start to be able to change clinical practice. And we really enjoyed being able to support regulators auditing. That's tongue-in-cheek. I've not enjoyed a minute of the regulators coming to audit us. But what it's meant is that for the first time in human history, there's an indication to treat people with chronic kidney disease, adults with chronic disease with an intervention. It's indicated for all patients with chronic kidney disease. Previously, the indicated treatments to treat kidney disease was specific to diabetes, and we'd had drugs like irbesartan approved, but nothing had really come through for 20 years until the SGLT2 inhibitors. And I've really enjoyed being introduced to the KDIGO and the European Society of Cardiology and the UK Kidney Association, where we supported by generating extra data from the trials, the information that people, the clinicians, need to reassure themselves that these drugs are effective and safe in different populations. And now there's wide numbers of 1A clinical practice guideline recommendations. 1A is the highest level of recommendation, and it had a major impact. It made Natalie Staplin, I've said this before, the most famous renal statistician in the world, as she's developed these work for the community. And it's left a legacy for the renal studies group. On the right is the old tier, the Collins, the Martins. I consider myself old now, the Johns and the Wills. And below is the group of people, the statisticians and the trainees and the DPhil students who have joined the group. And we've got some exciting results coming with post-trial follow-up reporting in October. We've got meta-analyses where we're combining data from other trials, sub-studies, and the biobank. And I'm sure it will keep us busy for the next 5 years or more, training the third generation who I'll need to convince to carry on helping us run trials as well as do the exciting science. But the unsung heroes are the administrators, some of whom are here today. This is a picture of them. They don't get any of the credit, but they do most of the hard work. And this is a photo of them. And then we've been really well supported by like-minded collaborators around the world. Colin and Martin brought them together in the belief of streamlining and randomization at scale. And in particular, Adir 11 and Masomi Nangaku have been incredibly supportive for me in my career within other organizations. I'm really grateful to them. And then my talk was the rise and rise, but I'm hoping you might see that renal trials rise again with Easy Kidney, because I'm a tenacious, annoying chap, as most of you know, and we've never given up on aldosterone. I never really give up on most projects, to be honest. So if there's anything I haven't quite finished, I will be coming back. But what happened during EMPA-KIDNEY is something very interesting, is that one of the other drug companies, Bayer, another German drug company, had done a trial in diabetic kidney disease and has shown what we had suspected is that aldosterone targeting actually slowed progression of kidney disease, and it also reduced risk of heart failure hospitalization, which is exactly the type of cardiovascular disease our patients with kidney disease, and particularly those on dialysis, succumb to. And what had happened was that during that period, drug companies had been developing something which was quite interesting, which was a new agent in this pathway. All nephrologists know this. This is called the RAS system. You don't have to know what the RAS means, but essentially it's activated and it's a bad thing. And essentially we know from the trials that if we target it by turning it down, down-tuning it, then we can actually down-tune that kidney engine and make it last a bit longer. And we've shown that ramipril, losartan, and irbesartan all work, and then more recently we've shown that finerenone worked. But we'd only studied certain types of patients. We hadn't studied the full range. But now along comes the industry developing new drugs on the same pathway, and they developed something called the aldosterone synthase inhibitor. So this is a type of drug which stops the aldosterone being produced. And there are drugs called baxdrostat, drugs called lorundrostat, and a drug called BI 690517. BI, what does that stand for, Guy? Very good. And just making sure you're awake. It was good. And so what we did was we convinced Boehringer. We said, we've done EMPA-KIDNEY. Look, it was in the middle of COVID. We got stopped. We got started. We delivered the trial, clear result. We delivered it on time. And the regulators have approved it for use in chronic kidney disease. We've got this international collaboration. They're following the patients, but we need to do more trials. We've only reduced risk by 28%. There's an enormous residual risk. We need to do a new trial, and we'd like to study 11,000 people, please. And to my surprise, they said, fine. And I think that's partly because a reflection of the trust that's been built up by the collaboration and the hard work that everyone has made. And we offered to do a trial where we would essentially take empagliflozin, which we demonstrated to be effective in a wide range of patients, the same population again, and we would study them. And this time we'd just do the same thing, but we'd try the next treatment. So we're moving on to the next question. And the next question was this aldosterone synthase inhibitor, which I can tell you today has now got a name. It's had its birthday. We've been calling it BI 690517. You're allowed to call it Vicadrostat from now on. I've heard Christoph and the Germans call it Vicadrostat. But I think I'm hoping it will be a stronger Drostat than a weaker Drostat. And we'll start to see that name come around. It's the generic non-proprietary name that the drug will be used and known as. And we're studying, as again, important outcomes, cardiovascular death or heart failure hospitalisation or need to start dialysis or a kidney transplant. And we're going to see if we can wait to 1,070 primary outcomes, but we might get stopped early if the drugs really works. And this is our dad's army plot. This is CTSU's orange. As we expand, we've needed to expand into South America. We're going to Mexico after our experience with Mexico. We've built collaborations with nephrologists through the cohort studies. We're going to go back to go down to Brazil and Argentina. We're going back to Australia and into India, and to my wife's home area, to Taiwan, as well as mainland China, and then also into Korea. So we're expanding our reach, which is exhausting, as everyone knows. And we've had to expand the steering committee, and again, we've had the same people put their hands up and volunteer again. And so I'm very excited to be working with the collaboration again for another 4 years. And Colin ruined my news, but you would have known because of the ice cream van that we did recruit our first patient on Friday. It did feel, as Rio said, like trying to launch a space shuttle. It did make me laugh because the first participant is an astronomer. And he's a lovely guy that turned up to clinic and was telling me about his astronomy, but he also told me he's been reading about a molecule called aldosterone. I couldn't quite believe it when he told me he thought his levels of aldosterone was high, because no patient's ever said this to me. No one's ever talked about aldosterone. And he said, could you measure it for me? And I said, no, but I can do something a little bit better. And I said, we've got a drug which will inhibit its production. Would you like to be the first patient in the trial? And so he was the man that came rushing in when we managed to get the IT system working on a Friday or Thursday evening. He accepted on a Friday morning to pop in, and he was screened on Friday afternoon, thanks to enormous amounts of work from Ben Story, Parminder, Lucy and Rajiv, and it has felt like almost everyone in CTSU at certain time points. It's been a new collaboration building an IT system. Rachel Raff's at the back, and we've got a new collaboration with Martin, who's disappeared off somewhat and set up a not-for-profit company generating IT systems for trials. And it's really, really lovely being able to support the development of the new IT system. And really, it's thank you to everyone that we got to this point. It's been an enormous amount of work. And I think we're all slightly petrified by the fact that we're going to have to deliver a trial in about 20 countries. And that was partly why I applied for this recognition and distinction. I felt if I was going around the world to tell people, please come and work on the trials, and I needed to try and propagate a bit like a missionary. CTSU's mission, I needed a title which people would listen to. So I'm very cautious now about what I say, because the word professor means that there is a danger that one of you might listen to what I'm actually But the reason I'm really proud to be able to represent CTSU is I really believe in what Rory and Richard have set up and what Martin and Colin have shown, which is that if we want to change clinical practice, we need to define definitive trials, which means large trials. And we need to base it on scientific principles and simplicity so we can integrate it into clinical care and recruit large numbers. And we need to challenge the barriers and the people that are trying to damage the trial infrastructure. And if we do that, we can start to see trials rise and rise again. And so that's what I have committed to do I suspect for the rest of my working days. And I'm really proud and honoured that the university has bestowed this upon me. I'm almost as proud as my mum, I suspect. I just wanted to finish by saying the 2 thank yous. And so there are 4 people who have spent an extra special amount of time looking after me. Colin, from the very start, who allowed me to join his group. I think I caused him all kinds of distress by my scientific writing. Phil had got me somewhere, but I still had a long way to go. And after 3 years here, he bought me a book on the use and abuse of the English language, which is still by my bedside. There's Martin, the Morris dancer from Bampton, who showed me how energy and logic applied to trial operations could change. And he had shown me how you could run around the world on planes and build a collaboration. And I followed in that model, much I suspect to the distress of my family, but much to the benefit of my fridge magnet collection. John taught me not everything he knows about statistics, but sometimes I think I might have got to the ceiling of everything he knows. He looked after me, he trained me from my MD thesis on. He recognised my pale skin is at danger when I'm in Mexico and made me wear this protective hat. Thank you very much, John. And then Richard, who is one of the most humble but most efficient and intelligent people I know, who's 3 years older than me, but it feels like an older brother who has been in the background, not taking any credit for EMPA-KIDNEY when really he did at least half the work. He's not here today. He found out that I was supposed to be in an investigator meeting in Australia today, and he offered to travel. I think that 44 hours on a plane was preferable to listen to 44 minutes of me dribble. But he hasn't said that directly yet. And then I'm really proud that I can now share with my family what I've been doing, because I think they may be completely blissfully unaware of what I spend my time doing, where I disappear off to around the world. This is the Herrington clan. My mum and dad, Julie and Alison in the middle, Sandy hiding in the background, always being supportive. A guy dangerously perched on a branch. Be careful there, you might injure yourself, Guy. You don't want to fracture your arm. But what really want to say to the family really is, once you see all these data, you can see what I've been trying to do with the team here. This is what CTSU does. I've been so lucky to have found CTSU. I was never expecting to find this mission in life. I've been so lucky to be trained by the family, and it's an enormous family here. I'm grateful, particularly to the people I mentioned, but also really everyone in the department. There isn't anyone I dislike, and there's almost no one that won't help you. And I feel like the department has trained me. I never did an MSc in epidemiology. I've just learnt through experience, through people's time. I've popped into people's lives and then disappeared after looking at some data, writing a paper. And I've done that systematically. I've done individual patient data, observational meta-analyses. I've looked at large cohorts with blood-based. I've done a bit of genetic epidemiology. I've done trials, meta-analyses. I've played around with accelerometers with Aidan, and I've learned something from everyone. I've stolen their time and their data, and then I've built my training, and I'm now really proud that my family in Oxford at CTSU can spend some time meeting my family from Kent. So. And back to training tomorrow, Guy.